My talk's going to be on ascites and analysis of peritoneal fluid. I shifted a little bit. I was going to include like thoracentesis and other things, but there's a lot of guidelines to go over and management of ascites, specifically in cirrhosis. And so we'll go over workup of new onset ascites and then shift into management of ascites in the setting of cirrhosis. Okay, so we'll go over definition of ascites, etiology, initial evaluation, the fluid analysis, management, complications, and then I have several questions at the end to go over. Much of what I cover is going to be from the AASLD, which is the American Association for the Study of Liver Diseases. This is practice guidance, not necessarily guidelines, and I highlight that because it's not formal guidelines, because there's not a lot of like large study, meta-analysis, randomized controlled trials, but this is really consensus guidelines or consensus guidance from the experts. So as far as definition, what is ascites? Ascites is the pathologic accumulation of fluid in the peritoneal cavity. So you have your peritoneal cavity. So this is the visceral peritoneum. The peritoneum that lines in the blue is what lines your organs. The parietal peritoneum is the red that is sort of like the outer part and lines the body wall. This is exaggerated just to show like where ascites can accumulate. Normally this is really collapsed and right on top of the organs. In males, you really shouldn't have any fluid there. You can have up to 20 cc's of fluid that is normal and physiologic in females, depending on where you are in the cycle. And so importance for our patients, it's important because this touches our hepatology, cardiology, nephrology, oncology. Pretty much all of our patients can have ascites for different reasons. And so knowing how to detect it and how to work it up is important. As far as etiology, by far and large, cirrhosis is going to be the most common cause of ascites that we have in the Western world. And then sequentially following that, you have cancer is another 10%, heart failure is 3%, TB, very rare, but an important cause to consider, especially worldwide. So most of our patients, again, are going to be portal hypertension and cirrhosis. Etiology of ascites with cirrhosis. So often this is the first symptom of decompensated cirrhosis. So we all know that like variceal hemorrhage, hepatic encephalopathy, kind of you have the other markers of decompensation, but ascites is often the first one to present. It develops in 5 to 10% of patients every single year with cirrhosis. Another way to kind of look at that is in 10 years, 50% of patients who have a diagnosis of cirrhosis are going to have ascites. The development of ascites is associated with a reduction in survival. So once you get ascites, your 5-year survival goes from 80 to 30%. That's not so much from the ascites itself, but it's what it puts you at risk for. So bacterial infections or SBP, electrolyte abnormalities, hepatorenal syndrome, and nutritional deficiencies are much, much more likely once you get ascites. And then just to talk, so cirrhosis is our number 1 cause. Malignant ascites is our number 2 cause of ascites. It accounts for 10%. And as you can imagine, just because of proximity, these are mostly going to be gastric or hepatobiliary cancers or gynecologic in origin. And then note that peritoneal fluid cytology has a pretty low sensitivity. And so even if you have a high suspicion for somebody having malignant ascites, one diagnostic tap with cytology is not sufficient to rule out malignancy. And so oftentimes you're going to have repeated attempts, like up to 3, and sending those for repeated cytology. So a sensitivity of 50% is on the lower end. As far as pathophysiology, in big, broad categories, the 2 ways you can think about ascites are: is it due to portal hypertension or is it non-portal hypertension, things like inflammation and oncotic pressures. So for portal hypertension, this is really going to be hydrostatic pressure, so buildup and backup of fluid and the sheer like pressure and volume that builds up behind the hepatic vasculature. Is the portal hypertension arm. And then non-portal hypertension are things like irritation of the peritoneal lining, malignancies, infections, and then hypoalbuminemia is going to be in that category. So this is another way to kind of like look at the same thing. So the blue boxes that you see here are portal hypertension. The red boxes are non-portal hypertension. And even though we think about cirrhosis as being the main cause of portal hypertension, it's important to note that like lots of other things can cause portal hypertension too. And when you talk about prehepatic, hepatic, and posthepatic, the prehepatic is sort of the venous flow into the liver. So prehepatic is going to be your portal vasculature. Intrahepatic, obviously, within the liver, and then posthepatic is going to be your hepatic veins as it drains into the IVC. So prehepatic things are mostly going to be clots in our patients. So portal vein thrombosis or splenic vein thrombosis are our prehepatic cause of portal hypertension. Hepatic, mostly going to be our cirrhosis. And then post-hepatic, Budd-Chiari or thrombosis of hepatic veins. And then your cardiac causes are going to cause backup of fluid and portal hypertension. And then when you get into the non-portal hypertension, this isn't even an all-inclusive list. There's many more causes than what's on here, but the inflammatory things are important to us. Pancreatitis, sarcoid, Whipple disease, infections. TB is going to be one that's up there for us. Lots of neoplasms. So we talked about the solid organ malignancies that were listed as the most common, but also lymphoma can cause malignant ascites. We had a recent patient who had blasts on her diff, on her peritoneal fluid. So lymphoma and leukemias can also present. And then postoperative and traumatic are the other two categories. And this is just more specific pathophysiology about cirrhosis and like why you get the development of ascites and how it contributes to the complications that you get. So in cirrhosis, you get portal hypertension. We already talked about fibrosis of the liver, backup of pressures, accumulation of fluid. And essentially you get backup within the sinusoids and the liver itself that backs up into the lymph tissue, and that alone contributes to ascites. This second category, this splanchnic vasodilatation, this is like hugely pathophysiology of cirrhosis. So you get increased nitric oxide that causes splanchnic vasodilatation within the abdominal cavity, redistribution of flow, and essentially your arteries sense that you don't have enough volume. And when you have arterial underfilling, that contributes to neurohormonal dysregulation. And so you get increase in renin-angiotensin, increase in aldosterone, increase in ADH. And so all of those three contribute to salt retention, fluid retention, and dilutional hyponatremia. And so all of this excess sodium contributes to ascites. The increased ADH and increased aquaporins, that is free water retention to try and like increase your systemic volume, is what contributes to the dilutional hyponatremia. And we'll talk about that more at the end. And then this last piece is bacterial translocation is important because it contributes to SBP. But the thought is that the bacteria also cause lots of inflammation, and that inflammation contributes to hepatorenal syndrome. Okay, so when you have somebody who walks into the emergency room and has ascites, these are kind of the things that you should go down the path of. History and physical. So as far as when you're talking to the patient, you're going to ask them about risk of chronic liver disease. Do they have a lot of alcohol intake? History of metabolic abnormalities. And then as far as like liver disease, alcohol, metabolic things, do they have risk factors for chronic hepatitis? Do they have a known diagnosis of hepatitis C or a different hepatitis? Heart disease, have they had hematologic issues in the past, either thrombosis or bleeding, thyroid and autoimmune disease, and then malignancy, pancreatitis, and then again, less likely for us, tuberculosis, but important to ask about in the right patient population. And then physical exam, I feel like some of this goes by the wayside now that we have ultrasound and you just like kind of put a probe on people and say, well, yes, there's ascites there. There are a lot of like physical exam findings, shifting dullness, where you kind of like check for tympanitic sounds at the top of the abdomen and have the patient lay on the side, and it shifts from the top of the abdomen over to the side. So shifting dullness. Abdominal masses or tenderness. Do they have a big umbilical hernia or inguinal hernias? Evidence of hepatic hydrothorax, where it's decreased breath sounds on one side. I did put in some stigmata of chronic liver disease that you may notice as you're seeing patients. So this is the classic like spider angiomas. These are commonly like on the top of people's chest or where like the SVC drains. It's got a big central arteriole, and then it's hard to see in this picture, but they have all these little like fingers that go out from it. This is classically in alcoholic cirrhosis. The actual number actually correlates to if you have esophageal varices or not. And so like after you transplant somebody, these can actually go away. These are related to the elevated estrogen that you get in liver disease, as well as some like vascular growth factors that change. Same thing with palmar erythema. It's not showing up great on the screen, but you get really significant palmar changes. That's also due to the elevated estrogen. And then some of these also, gynecomastia, also estrogen. These are abdominal wall collaterals or kebab medusa. That's from the portal hypertension that you can look for. It kind of looks like it's like the head of snakes, like in the theology. So it looks like snakes coming around the abdomen. And then peripheral edema, which we're all aware of. So as far as our guidance from the AASLD initial evaluation, these are the things that we should send if you see somebody with new ascites. CBC, BNP to look at electrolytes and renal function, liver function stuff, including albumin and INR, a urine with a spot urine protein, and then serum and urine electrolytes. There's a lot of other tests we can send, but these are kind of like the basics you should start with. And then if you have a specific suspicion for something else, then add on top of that. But these are our basics. And then you'll get an abdominal ultrasound with Doppler. We talked about that there's a lot of pre and post hepatic causes of portal hypertension. And so you really want to look at the vasculature, especially if somebody's coming in with new ascites. This is Budd-Chiari, like I was talking about, where you have clots right here in the hepatic vein. And so you're going to want a Doppler ultrasound to look for that. And then paracentesis with fluid analysis. For those of you who are familiar with ultrasound, this is what it would look like. Your probe would be here at the top. Black part is the ascites. These little cauliflower-looking things are your intestines, and so this person has a big pocket. And this is kind of what we're looking for when you look to see if somebody has like tappable ascites or kind of a quote safe pocket to do both a diagnostic and a therapeutic tap. Okay, so now you're ready to do a paracentesis to look and sort of see why the fluid is here. All patients with new onset ascites, worsening dissension, or symptoms of infection, and really anybody who has decompensated cirrhosis that's coming into the hospital, especially if they're ill, they should get at least a diagnostic tap. This is sort of what simple fluid looks like. All patients should have a cell count, an albumin, total protein, and cultures. So that's the basics. There's 20 different things on our paracentesis power plan. You really don't need all of those out of the gate unless you have something, if they tell you they've come back from Mexico and they have cavitary lung lesions and they have, okay, that person you could work up for TB, but for the most part, you really just need these studies. And then you'll look at the appearance of the fluid. So simple straw colored fluid, that's our typical ascites. If it's cloudy or milky, that may be associated with infection. Bloody fluid is often concerning for malignancy. Milky or whitish fluid can be a chylous ascites. So you can gain a lot too from the appearance of the fluid in addition to those studies. Oh, I should have asked. Okay, so you get an albumin on everybody. You'll from the BMP and the LFTs, you'll have a serum albumin. It just needs to be the same day as the paracentesis. It doesn't have to be exactly the same time. But this is probably the single most important test. If you have no idea why somebody has ascites, what you're going to do, it's called the SAG, or the serum to ascites albumin gradient. And it's exactly what it says. Your equation is the serum albumin minus the ascites albumin, and it's going to give you a value. By definition, less than a 1.1 milligram per deciliter difference is a low SAG, greater than 1.1 is a high SAG. And really, anything that causes portal hypertension is going to have a high SAG. The other things are going to have a low SAG in general. And that's really because it's really a pressure gradient. You're not really shifting albumin across the membrane. It's really just you have a high pressure and simple fluid is going across. And so the difference between the two, your serum albumin and your acidic albumin, is going to be high. In other things that cause a lot of irritation, you secreting proteins into the fluid, malignancy, infection are going to be our big ones. They are going to have a high protein content, and so your difference is going to be smaller. And so low SAG, think infection and peritoneal irritation. High SAG is portal hypertension. And then the main difference so this is our SAG, but I also included the column with the total protein. And so again, your cell count, albumin, total protein, cultures are going to be the things you send. The difference in how you tell if you have a high SAG, heart failure is going to have a high total protein, and cirrhosis is going to have a low total protein. So that's how you're going to tell the difference between those two. And then I put these on here. There's a longer list than what's here about when you should send other things. Again, it's really if you only have a suspicion for like a secondary bacterial peritonitis. So if you think that this is like sometimes bowel perfs, infection, things like that, or you're going to send a glucose and LDH cytology for malignancy. Amylase is associated with pancreatitis. Adenosine deaminase in tuberculosis, and triglycerides if you think it's a chylous but usually you'll have other reasons that you're suspecting these things. Okay, so that's sort of like your workup and what do you do with the fluid and what you send initially. Now I'm shifting into kind of like once you diagnose cirrhotic ascites, like how do you approach it? How do you manage the patient? And what other issues are you going to run into? So ascites can be graded based on the amount of fluid that's there and then what the recommended treatment and response to treatment is. So there's 3 different grades. Grade 1 is mild ascites. It's really only detected by ultrasound. You may not need to do anything, no specific recommendation. They may need sodium restriction, moderate dietary sodium restriction, and then may need a diuretic. Grade 2 is a lot of our patients, they have moderate distension of the abdomen, recurrent in that it recurs at least 3 times in a 12-month period, despite dietary sodium restriction and despite diuretics. And then the last, grade 3, is our large tense ascites. It's coming back every 4 weeks. They're getting serial large volume paracentesis. So those are kind of, we see this whole spectrum. So grade 1, grade 2, grade 3 are the grades of ascites. So management of ascites, what does the data show? So moderate dietary restriction, which is a 2-gram low sodium diet, kind of similar to our cardiac patients. They have to maintain a negative sodium balance to get net negative fluid losses. This is just often a reminder for us too to think about nutrition consults, especially for these people early in the disease course, because what happens is people will also restrict their sodium and then they'll start to restrict one of the late consequences is sarcopenia, malnutrition. And so like teaching them how to restrict their sodium, but also maintaining a healthy intake is important. So just a reminder, get nutrition involved early. And then severe fluid restriction is not indicated unless they also have moderate to severe hyponatremia. So with cirrhotic patients, their urine output is in general pretty low, like a liter a day kind of thing. So you're really gonna have to restrict to like a liter to make big differences in their abdominal fluid. And so sodium restriction and diuretics are going to be bigger bang for the buck than trying to limit somebody to a liter. And then diuretics, again, education enters here, educating on daily weights. If it is a very first episode of ascites, there's a study that shows spironolactone may be alone sufficient. If they have long-standing or recurrent ascites, then you're going to need the combo with spironolactone and mineralocorticoid receptor antagonist, also with a loop diuretic. The ratio to remember is 100 of spironolactone to 40 of furosemide. With the caveat being that in renal disease, you're going to have lower spironolactone and higher Lasix, just because of the, that's the perfect balance to try and like maintain your potassium. And so if you have more severe renal dysfunction, your spironolactone dose will be lower, loop diuretics will be higher. The maximum dose recommended is 400 of spironolactone and 160 of Lasix. So if somebody's on max diuretics, that's what they're talking about. And then just recheck labs. If you're starting somebody, you do a large volume paracentesis, you're putting somebody on diuretics, they need to see their PCP within around 7 days to check follow up renal function as well as electrolytes. And then up to 20 to 40% of people will have adverse effects from diuretics. And we all know these AKI, electrolyte derangements, either hypo or hyperkalemia. Painful gynecomastia, especially at higher doses of spironolactone, can be bothersome to people. You can switch them to a Clarinone or a Meloride, and they're less likely to have that specific side effect. And then people have muscle cramps on the higher doses of diuretics. So 20-40% is a lot. And, we all know that people stop their diuretics for different reasons. Okay, and then paracentesis. So it's the first line treatment for grade 3, that tense ascites, the really big visible ascites. If you're doing a paracentesis and you remove 5 liters of fluid, you're going to have to give albumin afterwards. There's something called post-procedural circulatory dysfunction. This is like the big fluid shifts that you can get. If you take a lot of fluid off the abdomen, more fluid is going to leave your intravascular space and go into your abdominal cavity. Those big shifts are going to predispose. Like I was saying, they already have a lot of vasodilatation. Their effective circulating volume is already low. And so when you do a large volume, you're going to worsen that. So if you don't give albumin, you're going to have AKI, and AKI with ascites is the biggest risk factor for mortality. So that's why we give albumin. It's going to be 6 to 8 grams per liter removed. And so if you take off 5 liters, you're going to get 40 grams of albumin. And again, if you don't, renal impairment, delusional hyponatremia, hepatic encephalopathy are going to be the things that you're trying to prevent. It's more common if you take off 8 liters. There's no cap to what we can do. We take 12, 13 liters off of people. You're more likely to have consequences if you're going above 8 liters. And then there is another caveat in the guidance and from the AASLD. It's that you could consider albumin even at lower doses. So if you have lower systolic pressures, your sodium's less than 130, or you already have an AKI, even if you take off 3 liters off this patient, you could still consider giving albumin, even though they're not at that 5 threshold, because again, AKI is the biggest predictor of mortality when you're doing this. And so if they're already at risk for that, then you can give albumin. There's actually several studies that look at giving like weekly albumin to these people. It's not yet in the guidelines, but a lot of studies are looking at twice weekly albumin followed by once weekly. So that may be something that comes down the pipeline as formal guidance in the future. So this is about refractory ascites. So we do see these people also who come in, every single 1 week. They're here. You're taking off 8 to 10 liters every single week. They're having side effects from this. They're on maximum diuretics, and you kind of either categorize these people of diuretic resistance, meaning they're on as high doses as they can tolerate, and they still have ascites that's problematic, or they are having side effects and they can't tolerate it. So either diuretic resistance or diuretic intractable. This occurs in 5 to 10% of patients with ascites. It's got very poor survival, 50% at 6 months once you reach this stage. And they're going to be managed classically with serial paracentesis. But if that isn't working, then you start thinking about TIPS and liver transplant. And so TIPS, just to note that if the male is greater than 18, they're poor candidates for TIPS. So this is what a TIPS is. It's where a transjugular intrahepatic shunt. And so they go in through the jugular, take a wire down, and essentially create a connection between the portal vasculature and the hepatic vasculature. And they balloon it open, create a stent there. So you have this huge pressure that's building up in this portal vein, and now you alleviate it and allow the blood to pass through. And so your pressure goes down because now you have a path of least resistance for the blood to follow through. The big problem with this is your ascites won't go away immediately. So you have to counsel people that this may take some time as like all that neurohormonal stuff sort of goes back to normal. But the biggest side effect is when you have ammonia that normally would be filtered through the liver, because even though it's slow, everything's still going through the liver before this. But now that you bypass the liver, you're not filtering ammonia. And so hepatic encephalopathy is the biggest risk after TIP. So your ascites is gone, but you may be at bigger risk of hepatic encephalopathy. And then I just thought this was really interesting. This isn't available in America right now. They've done trials on it, but there's something called the Alpha pump, automatic low flow ascites pump. And so essentially you put this battery powered pump in, and it has one catheter that goes into the ascites and one catheter that goes into the bladder, and essentially pumps it and puts it into your bladder, and you urinate out the ascites. So again, has had trials in America, not FDA approved here, but something that was interesting. So I couldn't not include it today. I know, one day. And then just a reminder for general medical management for these patients. So once you get ascites, again, you're at risk for AKI. And so reviewing these patients' med lists when they come in, oftentimes they're prescribed different medications from other people. So if NSAIDs are on their list, make sure and discontinue the NSAIDs in the setting of cirrhosis and ascites. And then also ACEs and ARBs can be problematic. So just cleaning up their list when they come in. Hyponatremia. So as you get more and more off the curve, when you have increased renin-aldo, increased ADH, you're going to get more and more dilutional hyponatremia, defined as sodium less than 135. So with cirrhosis, there's, again, another grading scale, mild, moderate, and severe. So mild goes 126 to 135. 50% of, I don't know if I included on here, but oh yeah. So 50% of patients are going to have hyponatremia. We see this all the time. It's so common that we just kind of, you see it and you think about it, but it's definitely not abnormal. Moderate is 120 to 125. Severe is less than 120. And most of the time, this is going to be hypervolemic hyponatremia. But remember to think about, even though most of them are volume overloaded, they're edematous, people are often dehydrated because of their diuretics or because their lactulose has been too high or has been increased recently. So think about hypovolemic, but most of the time they're going to be hypervolemic when they're coming into us. And then of note, a sodium less than 130 has very high risk of complications. So once you get hyponatremia, your odds ratio of all these things happening to you are 2 to 3 times without hyponatremia. Hepatic encephalopathy, hepatorenal, SBP. Because hyponatremia is such a bad portender of prognosis, that's why it was included in the MELD NA score. That was updated in 2016. And so previously it was just the creatinine and the bilirubin INR. When they started looking at hyponatremia and it got included in 2016, the sodium went into the score, and so then there was the MELD NA. Now, currently, what the transplant community is using, MELD 3.0, is what gets you on the transplant list. So in 2022, they updated to include disparities based on gender. So more men were getting transplants. And so now you get more points if you're a female. So now it has albumin and if you're a female, male or female on there. So we're in our third iteration of the MELD score. The first, the basic, the second because of sodium, the third because of disparities in gender. Hepatic hydrothorax. So this is a complication where you have ascites, normally you have ascites, and you have a diaphragmatic defect and you have negative pressure in your chest, just in your routine, like breathing in, breathing out. And so it kind of sucks fluid up into your thoracic cavity. 73% of the time it's going to be right-sided. So you should expect a right-sided hepatic hydrothorax. Doesn't mean it can't be bilateral and it can't be left-sided, but most of the time it's going to be right-sided. And so you should just think if you see a left-sided one and just be sure that's what's going on. For a first-time identification of this, they do need a thoracentesis to make sure nothing else is going on. Similar to the SAG, you're going to have same, if you check an albumin on the fluid, it's going to be a high SAG, just like your ascites would be. It also has a very high mortality risk out of proportion to MELD. So you can see all these, as you get more and more complications, your mortality risk goes up. Same is true for this. The average presenting MELD score is 14. That predicts a mortality of around 8%. But if you have hepatic hydrothorax, your 90-day post-hospitalization mortality is 74%. So very negative prognosis. And they also kind of factor this in when they're thinking about transplant. Your management is going to be very similar to ascites, sodium restriction, diuretics. If it's refractory, then TIPS and liver transplant. There's very, very, very few patients can have like an indwelling like Pleurix catheter, but most of the time you're not going to do that. And then the last complication I want to talk about is infections and peritonitis. So bacterial infections are present in 1/3 of patients who come in with cirrhosis. Those are spontaneous infections, SBPE, and then in decreasing order, UTI, pneumonia, and skin and soft tissue infections. So you should suspect infection in people who are coming in with those things, fever, hypothermia, chills, any localizing symptoms, but really just any decompensation. If they have hepatic encephalopathy or AKI, you should also be thinking, are they having an infection somewhere? And then SBP in particular, fever, abdominal pain, and tenderness palpation may or may not have an ileus associated with it, but 1/3 of patients may be asymptomatic. That's why we're telling people when they come into the ER, please get a diagnostic tap for us. I know they're not having belly pain, but they have big ascites, they still need a diagnostic tap. So we should be pushing the ER to get a diagnostic tap, or we should be getting one as soon as these patients are coming in. Yeah, and that's sort of what I say there. And then this is a picture from the New England Journal of Medicine that just shows like at the basis, it's translocation of bacteria that goes from your gut into the acidic fluid, essentially. But there's all kinds of factors that go into that. You have like your immune system is dysregulated. There's lots of the hepatocytes get a lot of leakage between them. Here you have changes to the intestinal microbiome. So it's at its most simple form is translocation, but there's like all these things that are happening in the background that are increasing the risk of infection for these patients. And just to clearly outline the difference, so there's spontaneous bacterial peritonitis, that's what we're talking about with cirrhosis. And then there's secondary bacterial peritonitis where you have inflammation of the peritoneal lining for another reason. Usually that's going to be some sort of like perforated diverticulitis or appendicitis, cholecystitis. Something else is going on in your abdomen. You have like leakage of contents there that are causing infection. SBP is where everything's intact, but you have this translocation of bacteria. Both of them are going to have an acidic fluid of PMNs or neutrophils of greater than 250. A note for SBP, this can be with or without positive cultures. So even if you have a cell count that's above 250 and your culture comes back negative, doesn't matter, your cell counts are high, you're treating anyways. The culture is positive, great. If it's negative, you call that culture negative nutracetic ascites, and you treat for your full course regardless. Initial management is going to be a third generation cephalosporin. Here we use ceftriaxone, 1 gram every 24 hours. You can use cefotax also. Think about those who are at risk or have history of multi-drug resistant organisms. Rocephin won't be quite broad enough for that. So if they have history of ESBL or other risk factors, nosocomial infections, things like that, you may need to start broader than that, Zosyn or meropenem. And then again, AKI, these patients, we're always thinking about their renal function. So just if in the presence of infection, monitor their renal function really, really closely. This is another indication for albumin. So we give albumin post-paracentesis. You give albumin if they are diagnosed with SBP. And so the dosage is going to be 1.5 grams per kilo on day 1 and 1 gram per kilo on day 3. And that's associated with improved survival. You're going to follow clinically. Consider repeat paracentesis at 48 hours. A positive response is a decrease in their PMNs by 25% of whatever their initial count was. If they're not improving, then you may need to think about changing therapy. And then duration is going to be 5 to 7 days. And then there's primary prophylaxis and secondary prophylaxis. So primary prophylaxis means you don't have an infection yet, but you're preventing one from happening. That's indicated in patients who come in with GI bleeding. So, in addition to our 2 large bore IVs, PPI, octreotide, Rocephin should be on there. As far as SBP prophylaxis, maximum of 7 days therapy in that setting also. And then you can also consider primary prophylaxis in patients when you do their protein count, when you do their paracentesis. If their total protein is less than 1.5, you can consider primary prophylaxis for those patients too. I don't see us doing that all the time here at UAB, but that is in the guidance from the AASLD. And then secondary prophylaxis, so patients who have come in, they're treated for SBP, and now they're going on lifelong preventive prophylaxis. After that, that's going to either be with a fluoroquinolone, norfloxacin is what the studies were done with. Here, ciprofloxacin, 500 a day, or 1 double-strength Bactrim a day. And then again, you can consider if their total protein is low or if they have some of these other indications, and then they'll get lifelong prophylaxis. So in conclusion, portal hypertension and cirrhosis is the most common etiology of ascites. New onset, you're going to get your CBC, BNP, LFTs, including albumin and INR, urine studies, an abdominal ultrasound with Doppler, and a paracentesis. Once you get your peritoneal fluid, you need a cell count, albumin, protein, and cultures, plus minus other studies if you have specific concerns for something else. A SAG and a total protein are very helpful to determine the etiology. A SAG greater than 1.1, portal hypertension, less than 1.1 are your other etiologies. Sodium restriction, diuretics, spironolactone and furosemide at 100 to 40 ratio, and large volume paracentesis are the mainstays of therapy. And then associated conditions are hyponatremia, hepatic hydrothorax, and SBP. So that is... Does anybody have any questions before I go into the cases? Okay, I'm going to call on people if people don't raise their hand. Okay, so question number 1. 53-year-old male, past medical history of decompensated cirrhosis, has hep C. He has all these varices, ascites, hepatic encephalopathy, heart failure. He has peripheral vascular disease. He's got opioid use disorder, DVT. Sounds like our patients, right? So he comes in for hypokalemia and hepatic encephalopathy. He underwent a diagnostic paracentesis as part of his infectious workup. Does he have SBP? Okay, so how many white cells are in his fluid?
Because don't you have to compensate for the red blood cell?
You do. I'll show you that in a second. Okay, so on ours, this is the total nucleated cells. This is your white cell count, total white cell count, which is an absolute number. So this is, 400 cells there. So you have total 400 cells. This Pauli's line is tricky because now it's 36. This is an absolute number. This is a percent. And so you're going to have to do your own calculation on this. If I did my math, did I do my math wrong? 129 is what I got. So no, the patient doesn't. The threshold is 250 for SBP, and we only have 129, no SBP. So this number is deceiving. You have to look at your percent. And the only other thing they'll say, sometimes these, once you get it broken down into your types of white blood cells, these should add up to 100. So 53% plus 36, 89% plus 11, 100%. So you're counted.
For if it's SBP or just, it should total up.
It should total. So sometimes there's another category here that says other. So, and you have to click on that and it'll tell you what it is. If they think it's mesothelial cells, if they,
total up to be 100.
it's got to. Because it's a differential, right? Like you have 100% of cells and you break it down into the populations. And so once you break it down, the sum of the parts has to be 100. And so sometimes that's what I'm saying. There should be another column that says other. I can't remember if it goes down here or right underneath these. But that's like the patient I was saying that had blast on it. It's not going to say blast. It's going to say other cells. And then you click on it and it's like, 20% blast.
Somebody has been like at 250. Would you just treat them for SBP?
I would treat. And then Mary Griffin asked about the red blood cells. So you can subtract 1 TNC for each 750 red cells, and then 1 PMN for each 250. So like this one is a pretty good tap, so you're really not going to correct. So this one's pretty accurate. So anyways, just remember total cell count. These are percents. You take your total nucleated cells, your total white cell, your total white blood cells, and multiply it by your percent. And that's how you're going to get your PMNs. Okay, question number 2. A 60-year-old male, past medical history, decompensated NASH, has HCC and ascites. He also has smoldering myeloma. He's not been on therapy, follows with UAB on these are all real patients, by the way. Celiac artery stenosis. He came in for shortness of breath, jaundice, weakness, ascites, and edema. He has hyponatremia and AKI. He's anemic to 6.8. He doesn't have any fever, abdominal pain, tenderness, nausea, or vomiting. His MELD 34. Does he need a paracentesis? Yes. Okay. Easy one. Softball. Yes. He needs it. He has no signs of SBP, but he's coming with AKI, GI. He needs a diagnostic. If somebody's coming with an AKI, you're probably not going to want to do a large volume paracentesis right out of the gate, but at minimum, you need a diagnostic paracentesis. Okay. Yes. Even in the absence of symptoms. Okay, 64-year-old male, history of NASH cirrhosis, history of ascites. He's been getting weekly large volume paracentesis to manage his ascites. His last evaluation in liver clinic was a month ago. They didn't see any fluid when he went at that time, so they deferred the procedure. So he comes into the emergency room with 3 weeks of progressive shortness of breath. Is this hepatic hydrothorax?
Well, it's left-sided, so it's less likely, but you said it doesn't look good.
Right.
You have to do a thora.
So this gentleman did end up getting a Thor. So yes, you should say, this is odd. Like I didn't exactly say it in there. He hasn't had hepatic hydrothorax before. This is his first, he'd had a CT 2 to 3 months ago that had no evidence of a pleural effusion. So now he's coming in with a very large left-sided, not right-sided. He really doesn't have any ascites now. They tried to tap him, there's nothing there. Now he's coming with a big effusion. So 9% of patients can come in with hepatic hydrothorax and have no ascites. Most of them are going to have clinical ascites also. So it's the wrong side. It's come on very, very quickly. And his actually has like tracheal deviation and he has a tension. So this gentleman actually had
What's that big circular thing in the?
something external to the patient. So no, he needs drainage and fluid analysis. This is likely not hepatic hydrothorax. And then when you see him and talk to him, he gives the additional history that he was seen at an outside hospital a week ago, and he was told that he had a lung mass there. So it wasn't as full and didn't have as much tension, so they could see a lung mass when he was there before. So it's the wrong side. It's come on very quickly. Most of the time, hepatic hydrothorax doesn't cause a tension hydrothorax like this. So again, it could be left-sided, but it should just make you think, is there something else going on? Okay. 45-year-old male, history of alcoholic cirrhosis, comes in with 10 ascites. He missed his outpatient clinic appointment for a paracentesis. The procedure team is consulted. His labs are at baseline, and they remove 9 liters of fluid. What concentration and dosage of albumin should be given? Okay. What do you say? 72? Okay. So 25%, 75 grams albumin.